Trans Agency Consortium of Trauma Coagulation Workshop by the National Institute of Health. So that's short about the history. Now, trauma-induced coagulopathy can be defined as an impairment of blood clotting that occurs after from birth to the same workshop. So there are two phenotypes for trauma-induced coagulopathy. We will be more concentrating on the early trauma-induced coagulopathy. The second phenotype is the late trauma-induced coagulopathy. So the early trauma-induced coagulopathy is basically the inability to achieve hemostasis, which lead to uncontrolled hemorrhage and protracted shock. So what is the driver for an emergency or an early trauma-induced coagulopathy? It's again hypoperfusion and hypotension. So hypoperfusion and hypotension produces coagulopathy, which in turn increases hemorrhage and again produces coagulopathy. The late TIC, however, is the main driver is basically the level of the tissue injury, and it occurs more than 24 hours, and it is characterized by thrombosis. So the pathophysiology has two different settings. One is hypocoagulability, and the other one is hypercoagulability. Hypocoagulability is explained by hyperfibrinolysis, platelet dysfunction, decreased thrombin generation, fibrinogen degradation, while hypercoagulability, increased thrombin generation, platelet activation, hyperfibrinogenemia, and fibrinolysis. You can see that it's at the extremes of both. Coming to early trauma-induced coagulopathy in detail. First, we have endothelial dysfunction, which will produce tissue plasminogen activator, which will convert plasminogen to plasmin and result in protein degradation. Tissue injury also will produce end products like histones and polyphosphates, which contributes to platelet dysfunction, which again results in clot degradation. And any clot is actually maintained by the balance between the fibrinolytic agents and the thrombotic agents. If there is a reduced number of fibrinolytic, antifibrinolytic agents like TAI, TAFI, again this will result in clot degradation. Coming to what we do when we restate, we produce hemodilation. There could be some amount of acidosis. There could be some amount of hypothermia. All these are non-risk factors for decreased thrombin generation. So hemodilution up to 50% does not affect the clotting mechanism. Acidosis has a very profound. Acidosis can decrease the thrombin generation basically in the propagation phase by around 50%, but it does not affect the initiation phase of the coagulation. Hypothermia, any temperature 30 degrees Celsius, 30 degrees Celsius, not produce coagulation. Now there is always an ongoing debate whether ETIC is just another name for DIC. But if you look at the data, you can see that ETIC thrombin levels are decreased, while in DIC it is normal. The factor 3, factor 5, factor 7, factor 8 in ETIC, but normal in DIC. The plasma activator inhibitor is decreased in ETIC, while it is normal in DIC. Now, if you go to the viscoelastic assays, then you can see that if it is hyperfibrinolytic phenotype, the TEC LY30 is increased in ETIC but normal in DIC. If it is a fibrinolytic shutdown phenotype, which is late DIC, ETIC increased and DIC is normal. So there is definitely difference between DIC and trauma-induced coagulopathy. Now, how can we predict early trauma-induced coagulopathy? So there have been a multiple scoring systems. One is coagulopathy of severe trauma. Is coming from the Australian system. There are 5 components, mainly entrapment, systolic pressure, temperature, chest decompression, abdominal or pelvic content injury, and highest possible score was 7. So, with a cutoff value of 3, the sensitivity was 60% and specificity was 90%. It's an external validated score. The second scoring system, which is usually used, is the prediction of coagulopathy of trauma. This had a validation and a derivation cohort, but the exclusion criteria and the inclusion criteria in the validation and the derivation cohort was not so the external validity is questionable. It had multiple variables: depth, shock index, age, mechanism of injury, not motor vehicle, motorcycle or bicycle crash, number of PCS points below 50, CPR, hospital incubation, etc. The total points were around 394 per age, and any score of more than 196 was considered to be a predictor for acute coagulopathy of trauma. Having said that it has a specificity of 72% and a sensitivity of 73%. Then came the age of AI, artificial intelligence. So they used the data from a study called ACID, and they defined with different variables which could produce coagulopathy. So basically, they did it in these sub variations. You can see that they did tissue injury, tissue hypoperfusion, acidosis, hypothermia, and hemodilution. These were the drivers which we have discussed in the pathophysiology of early trauma-induced coagulopathy, and they looked at other things which could contribute to this particular mechanism which could contribute to the trauma-induced coagulopathy. And they did a Bayesian network model, and this has a sensitivity of 90%. This has a specificity of more than 92%. So during your primary survey, if you want to look for coagulopathy, the basic testing which you're going to do are the hemoglobin value, PTINR, your APT values, platelet count, and if you have access to a elastic testing method, a ROTEM or an RTEC, platelet function test plus or minus based on your basis of ethnicity. The other thing which you could do was a blood gas analysis for base deficit lactate value and pH value. So what is the major difference between a conventional coagulation test with a viscoelastic test? So conventional coagulation tests usually will have PT, INR, APT, platelet count, and T-dimer, while the viscoelastic would be either TEG or ROTEM. The measurements in conventional coagulation tests is basically to identify the rate of clot formation, absolute platelet number, and is there evidence of clot breakdown. But viscoelastic tests will give you something else also. It will give you the clotting time, it will give the kinetics of the clot formation, it will also give information about the clot strength, and also will tell you about the clot breakdown. So in coagulopathy, conventional coagulation test indicates the factor of fibrinogen deficiency only. But while that in viscoelastic test, it indicates factor deficiency, fibrinogen deficiency, indicates platelet and fibrinogen dysfunction, and indicates enhanced fibrinolysis. So this is basically TEG and ROTEM, where coagulation time and coagulation factors is set by the R or the CT time, clot kinetics by the alpha angle, CFT or kappa, TEG or ROTEM. The clot strength is by the maximum amplitude or the MCF, the clot stability by ML, LY30 or LI30. So when do you diagnose coagulopathy? So you diagnose coagulopathy when there is an extension of more than 3 seconds in the PT, more than 3 seconds in the thrombin time, or if it is more than 1.2 or 1.5 classically in INR, but most of the studies now put 1.3. A APTT extension of more than 10 seconds, fibrinogen value of less than 2 gram per liter, D-dimer of more than 5 microgram per liter, and a count of less than 125, 1,50,000 per millimeter. Again, there are different waveforms which you can associate with clot, which says that the patient is having coagulopathy. Now coming to the management. The first thing which we have to consider is how to stop the bleeding, because when the bleeding is ongoing, it will again coagulate. So accurate identification of the patient, bleeding patient, and damage control resuscitation is very important. You have to use a lot of hemostatic methods, tourniquets, pelvic binders, hemostatic or even Lipova. Thromboelastography, coagulation monitoring, tranexamic acid administration for those who with substantial hyperfibrinolysis should be employed. There should be a decreased time to the operating table or intervention radiology to curb the bleeding. There should be a goal-directed resuscitation with blood product. Now, what are the goals? We will come to that. Before that, we'll just look at the evidence basis for different treatment mechanisms. One is tranexamic acid. So, first study which told us that tranexamic acid can be useful as a crash trial, multi-international RCT. But if you look at it, most of the patients in the crash 2 trial did not require large amount of transfusion. But there was a subset of population in which tranexamic acid was very useful. That was the patient with shock. Again, it did not show any large complications in this data. It was a very huge data, but amount of complications in this study was very. Then came the MATTER study, which was done in the military setting. It was a single center observational study. They also told that tranexamic acid is going to help in those patients who require massive blood transfusion. But there came with a rider. The rider was that thromboembolic disease was increased by 9 to 10 times to those patients who would not get tranexamic acid. This was followed by MATTERS 2 trial in 2013, where they tried to give cryoprecipitate along with tranexamic acid and found that those two given together has better chance of controlling the bleeding. The last and the final trial which came was pre-hospital use of anhistaminic acid in the form of patch trial. It was negative trial, saying that anhistaminic acid did not influence the morbidity of the patient at now, evidence of using massive transmission ratios. The first idea of massive transmission ratio comes from the first cohort study called the PROMET study in 2013, where they said that those patients who are receiving high ratio of RBCs to platelets and plasma had a high early death. Within 6 hours, the death was higher in that group. So they proposed a 1:1:1 or a low plasma IFFP platelet ratio. This was further emphasized in the proper trial in 2015, which was a multi-center RCT, which compared 1:1:1 to 1:1:2 ratio and found that there is no actual difference, but 1:1:1 is taken preferred. Cryoprecipitate also came into the picture. They wanted to give early cryoprecipitate in cryostate trial and found out that there is no basic. Cryostatic trial 2, again, they brought in cryoprecipitate, give 2 pints of cryoprecipitate early in the resuscitation, but then it was also found to be not effective. Now coming to viscoelastic theory, viscoelastic method used management. The Cochrane review in 2015 told us that the diagnostic test accuracy was based on the diagnostic test accuracy for TEG and ROTEM.